Thank you for having me today. As Alex has said, we are going to present Compare EU project. I'm one of the researchers in the project, which of course is a larger consortium, and I'm delighted to represent today all the work that we have been doing in this consortium. Just a little bit of what I was going to speak today. As you can imagine, as all the European projects, they are quite broad in everything they do. So I have tried to focus my presentation in some of the topics that we have addressed in our project that are either, I think, relevant for you in your study of adherence, and then also specifically in the development of our platform, as Alex was said, where we try to include all our results and we try to tailor it for different stakeholders. So hopefully it will resonate with you and we will be interested with you. Just a little bit of background on our project. Of course, I think all you here and who will be listening to this webinar, we are all aware of the impact of chronic conditions, how they affect all of us, especially as we get older. They also, the incredible amount of, in terms of disease burden that they represent, and of course the healthcare costs that are associated with chronic diseases as well, right? And this has made a lot of people interested in putting people in the center and in involving them in a more active way, so that they can take part of their day-to-day care. But of course, this has been in the public discourse for some decades, but maybe it is not so well translated into the reality in our day-to-day life in how the healthcare systems take care of people, right? But one of the things that has been developing in this broader change of paradigm has been the self-management interventions. For our project, we use the definition of self-management as everything that individuals, but also families and communities do to promote, maintain, or health or cope with a disease. And self-management can be done with or without the involvement of healthcare professionals, of course. But in our case, we are specifically interested in self-management interventions. In this case, we would include an intentional involvement of the professionals or a system or a technological application that has a specific intention of improving the self-management of that chronic condition. Now, there has been a lot of research and a lot of developments on self-management because there's a lot of interest and we know that they can improve clinical and other patient-relevant outcomes, but it's still complicated to know which are the best interventions to do so because there's a lot of complexities in the evidence that we have. Among the issues that increase the complexity, we have a low concordance of measurement of outcomes across studies, right? Some studies maybe are focused on studying adherence, and then some studies studying other interventions just study quality of life. But it's hard to compare when they are using different outcomes to measure effectiveness. And even more, sometimes the outcomes that are measured are not the most relevant outcomes for patients. And this is particularly important in self-management interventions because if we are telling the patient to be active in their own health, it should be for something that they get a reward that is relevant for them. A lot of times maybe they can tell, okay, this specific clinical outcome is not relevant for my daily life. I don't see the incentive to do this if this is what you're focusing. Whereas if you do it, if you work with someone for an outcome that's relevant for his or her life, it's much more plausible that they would like to be involved and they would like to take an active role. So in this context is that we developed the Compare EU project. Our main goal was to transform the current evidence about self-management interventions in chronic diseases into more actionable evidence for the different stakeholders. We focused our research in 4 chronic diseases. As you can see here, there were COPD, heart failure, obesity, and type 2 diabetes. Within all the possible iterations of chronic disease, our research has been focused here. Now, as Alex said, we always had in mind that we wanted to have one of our final end products is a Compare EU platform that includes all the relevant results that we have and that are tailored for different stakeholders. I think probably like in your project, you most likely will have some results that are relevant for an individual patient, but then also you probably have some results that are relevant for decision makers at the national level or the European level, and then maybe some other results that are very specific, maybe from researchers or for the industry as well, in your case, if they want to further develop adherence technologies, right? So we also had this sort of conundrum of having like so many different stakeholders where we thought we could contribute a little bit with our results. So I will explain you some of how we have tried to present our results in a way that's friendly to the different stakeholders. We are still in, let's say, the beta testing of our platform, so we still want to introduce some improvements, but you will already see some of the products that we have. So first of all, just very briefly, I wanted to mention that we had to develop a taxonomy of self-management interventions for chronic diseases because, as I said, this is a very open field, and there are a lot of interventions that say that they try to promote self-management, and they are very different among them. So what we did here is just a literature review. We did a conceptual mapping, and then we had a Delphi method with experts, 2 rounds of experts, to try and have an homogeneous definition of self-management interventions and the components that form self-management interventions. The result of this is that we managed to get a consensus on the characteristics. The main pillars of how we define an intervention are the intervention characteristics themselves, but also, as you will see, the type of outcomes. So for example, in the intervention characteristics, we subdivide between the support techniques that the provider gives, but also how this is delivered. It's very different to deliver something remotely or face-to-face, the type of provider involved, the location, what type of characteristics of the recipient of that intervention. Then we also thought that it was very important to define the target population by characteristics of the recipient, but it could be also by characteristics of the disease or socioeconomic characteristics. And we also included what behaviors are we trying to modify when we do self-management interventions. It's not the same if we want to change how they take the medication, or if we want to change a lifestyle behavior that is more related to healthy eating or physical activity. And then finally, we also looked into what outcomes are you pursuing. I might think that if I change physical activity behaviors, I managed to also get changes in blood pressure. So we wanted to have all the chain of the intervention. And just a little zoom here at the types of support techniques in self-management that we saw in the literature is this list. So from sharing information, that's the most basic type of support you could give, to maybe more ambitious interventions that are out there, like shared decision making, for example, or establishing action plans and goal settings with the patient. Now, another thing that we did that I think is relevant is that we tried to establish core outcome sets. Core outcome sets, probably most of you know, are sets of outcomes that are agreed in a community of researchers and stakeholders that are relevant to measure the effectiveness for a type of intervention. In our case, we did this as well with the literature review, also a Delphi, in this case, involving patients with chronic diseases, where we asked them what are the outcomes that are more relevant for you in self-management interventions. And then we had a final consensus workshop with other stakeholders as well to prepare the list. And then once we had this list, we also looked into how many of those important outcomes were actually analyzed in the literature. And these are the results. Here you can see the list of outcomes for each of the diseases that we analyzed that were prioritized, as I said, by patients, and then also agreed with other stakeholders like clinicians and researchers. You can see there are some that are transversal and are very evident, like, for example, because we study self-management interventions, all of the diseases, they agreed on some elements of empowerment and activation of the patient were very important, of course. You will probably be happy to know that patients also agreed that adherence was one of the most important outcomes that were relevant for them in how we can help them to adhere better to the medication, but also in the cases of self-management interventions to other behaviors like physical activity or self-monitoring, not only taking the medication, but monitoring symptoms, etc. Then you can see we also, what is interesting, for example, is that sometimes the patients, they don't prioritize what would you expect. For example, In obesity, the patients told us that they didn't want to prioritize weight management, that they were tired of always having everything surround around weight. And we also have other important things in my life. I want you to help me to deal with other outcomes. In this case, we included weight management for research purposes, and clinicians wanted to prioritize it, but it wasn't the patient priority. And then just very briefly, as you can see, patients also prioritized elements of quality of life. Curiously, only COPD prioritized the involvement of the caregiver and their quality of life. This sort of makes sense because usually patients with COPD are more dependent on their caregiver than, for example, patients with diabetes. You can see as well, all of them wanted to be involved in their care. So participation and decision-making was very important for them. And then there was always some measure of even the healthcare use and the cost of, the intervention. Even patients recognized that this was important to consider. Now, here you can see color-coded, where you can see how much the literature actually analyzed each of those outcomes, right? We know what is important for patients. Let's see if the literature is researching what is important for patients. As you can see, there are a lot of reds. So there are a lot of things that we agree are important, but we are still not doing the research for those outcomes. So this is like, from us, this is a call for the research community that they have to do better. Now, if you can see in the level of adherence, there are some outcomes that are analyzed, but it's still very few outcomes, very few studies analyzed adherence in a systematic way. For example, I think you are particularly focused on adherence to medication. You can see that is analyzed in diabetes and heart failure a little bit more, but only 13%, 12.8% of the studies, and even less in obesity and COPD. So even if we all understand that adherence is crucial to see if we are effective with a medication or an intervention, it's still very seldomly analyzed. So we need to do better as a research community and be more consistent with what we measure. And as I said, this is like our call for the community for future to take this, be a more consistent and include the outcomes that are important for the clinicians, but especially also the patients. Now, in the CompareU platform, we included some of those results in a way that we thought would make it a bit usable. In this case, for example, we think it's especially usable for researchers. So we have a repository of different types of information that we have analyzed. In this case, for example, we have a repository of tools that study adherence, because for us, for example, it has happened that we want to analyze, we have to start a trial, but it's hard sometimes to find the tool to measure an outcome that you want, right? It's sometimes complicated. So we included this sort of catalog of tools. So for example, in our platform, you could see like, okay, if I go for diabetes type 2 and I want to see tools for adherence, you could see that in the literature, we found studies using, excuse me, these 6 types of tools for adherence. And then if you were to go into our platform, you could then go into the detail of each of those tools. You could see like the description and for what population it is used, in what languages it's available. And then what I think might be interesting for you is also the related RCTs that we found that use these tools of adherence in their research. So this would be relevant. I think I hadn't included in my slides, but when I was listening to Alex, I thought, well, excuse me a second. Sorry. So when I was listening to Alex, I thought that you as a consortium might also find interesting that we have, sorry, bear with me a second so I can see my navigation. Yeah, because with the Zoom. So you can see, for example, here we have another repository, and this case is directly with randomized controlled trials that we have found that analyze self-management. So here, for example, I have already filtered for heart failure disease and for your outcome of interest, adherence to medication. And here you can already see all these different studies that have included adherence in their analysis. And I think you will also see that a lot of them include some element of technology. So I think this is probably, if you want to catch people that are using technologies for adherence, this is probably nice for you. And you can hopefully you can find some interesting studies that are relevant. Okay, so back to the presentation. Okay, so now we had like a consensus on how we were defining interventions, and we had a consensus of what outcomes were important and we would try to capture from the literature. As you saw, we already identified that there was some evidence lacking in the literature on some of the important outcomes. But our next step is, okay, how we determine effectiveness of the self-management interventions. Here, I'm going to give a bit of background just because I'm not completely sure about all the background of all of you. If someone finds this very basic, please bear with me, but I just rather give it so we are all on the same page just in case. So, of course, one of the most advanced techniques that we have so far to synthesize literature is the meta-analysis of RCTs. But of course, this has still some limitations. For example, this is very often you have studies that are analyzing against different outcomes. So then it's very difficult for me to decide which of the interventions is better. So for example, if we were thinking of an example, I could be reviewing the literature and I found one meta-analysis where I can see that education is better than having only usual care, that having some sort of educational program is better. Okay, and then I see another study with a meta-analysis where I can see that if you have patient groups where they exchange some sort of social support, this is also better than having only usual care. But then I always left with the doubt of, okay, but what is better, education or patient groups? If they are not compared in a study directly, I cannot conclude it from a meta-analysis. And this is where a network meta-analysis can help us to actually compare all interventions that have that are of interest for us. So this is an example of how a network meta-analysis could be plotted. So here you can see like a node represents all the clinical trials that have analyzed a specific intervention, and the size represents the number of studies. So the bigger the node, the more RCTs that analyze that intervention. The lines here represent how many studies compared those two interventions. So the thicker the line, it would mean that there are more studies that compared those interventions. In this case, for example, you could see like, okay, a lot of people have studied exercise support compared to usual care. But you also have sometimes nodes that are not connecting across them. This means that no one has compared in their study directly, for example, internet reminders and exercise support. But what is nice about a network meta-analysis is that you can also do indirect comparison. So because you have the network, you have an assumption sort of saying, okay, if I know that exercise support is better compared to usual care, and internet reminders is good against usual care, but I know a bigger effect is here in exercise support, I can assume that exercise support is also better than internet reminders. Anyway, this would allow us to have sort of ranking of the intervention, and we will know, okay, for this specific outcome, the best intervention is exercise and support. The second one is internet reminders, and so on and so forth. But of course, as you can imagine, all techniques have their limitations. And one of the limitations that we see is that sometimes you have very complex networks. This is a representation of what we could find with self-management interventions, right? Reality is never so straightforward as you would like. In our case, because we had our taxonomy, this helped us a little bit to synthesize the information and to group interventions that were similar to them. But there was always a balance. If you group the interventions too much, this means that you have very different interventions in the same group. So it's hard to get like a robust conclusion because you mixed in a lot of things. If you do very specific interventions, you have very limited studies that have studied specifically that intervention. So it's still complicated to get a conclusion because you are comparing very fractioned studies. And this we have to say that we have faced this challenge in CompareEU because there was a lot of slightly different interventions. Just to show you what were the networks that we found in our analysis of adherence. And this was the network. You can see, wow, there's a lot of people that have studied adherence. I was telling you before, this is only 12% of all the studies that studied self-management in diabetes, but still there's a lot of evidence there. But because the interventions are very slightly different across them, it's very hard to make sense of all this evidence, right? If you are a clinician and you're trying to improve adherence, oh my God, how do I make sense of this? In our case, in the case of diabetes, we included adherence in a general definition. So this is quite broad. In this case, the network, it includes sometimes things that are not medication, they are specific behaviors. But for example, in heart failure, we were more focused on specifically adherence to medication. And you can see here the network is quite more simple. But you can see as well that in almost everything is compared to usual care, which is this big note here. So if we hadn't done the network meta-analysis, it would be very hard to conclude, right, what interventions are best in each case. Now, what we try to do in our platform is to make it a bit more understandable for the reader than, of course, seeing this. And what we have is this, what is called summary of findings. Probably you have come across this if you are a clinician or researcher. This is like following the GRADE methodology, where you have like one of the steps is to have a summary of findings. So for example, here, if you were to go to the platform and select our summary of findings, and you say, okay, I'm interested in the patients with diabetes, and I'm specifically in the outcome of adherence, you would have this sort of list where you would have interventions ranked by the T-score, so from bigger effect to smaller effects, and you can see as well the certainty of the evidence. You can see here in many cases it's low or very low because, as I said, the literature is very fractioned, so it's hard to get robust conclusions. And you can see that unfortunately we haven't found super strong evidence on changes of adherence. So you can see that there are small effects on adherence, even in the best of cases, at least for diabetes. And then with the same sort of report is for heart failure. You can see here that in this case, we see a bit of a bigger effect, a more robust effect for heart failure. You have to bear with us because, as I said, it's still on beta version. So you will see that some of the sentences still have some strange in the text, but we are working on it. So if you go in 2 weeks, you'll probably be already nice and polished. But the results are those. You can see the ranking of interventions, which are the ones that are having more effect on adherence. Here, it can be also interesting for you because, for example, here monitoring techniques usually involve some sort of technology, and they are the ones that are having the bigger effect in adherence to medication in heart failure from the self-management perspective. Now, of course, this is information outcome by outcome, but a lot of people are not only interested in adherence, right? I think you probably had discussion. Adherence is important, but adherence for what? I want to then, if I increase adherence, I would expect to improve blood pressure or improve weight or improve glycosylated hemoglobin or whatever outcome or quality of life, right? So I'm not only interested in one outcome. I want several outcomes. We have this sort of complexity, but also what we found when you think about translating an intervention in reality, you are also concerned about other things. One of them is cost effectiveness, right? I can have a magnificent intervention, but if I have to spend 1 million euros per patient to only slightly increase adherence, I'm probably not going to implement this intervention, even if it's very nice. And then contextual factors, right? Sometimes, okay, oh, you have an RCT, is super nice, but it was implemented in Norway, and I'm trying to implement it in southern Spain, and maybe the conditions, the health system, et cetera, are very different, and maybe I cannot just simply implement that intervention. I need to think about the broader picture before I go ahead and I take on that intervention, right? So we tried to contribute to simplify, to give some information on those aspects. And for this, we used the GRADE approach. What we had first is a panel where we had clinicians, other researchers, and also patients involved. And their first task was to help us to even further narrow the outcomes of interest, because you could see now, even if of course we had a long list for each of the diseases, so we said, okay, we are gonna focus on the more critical outcomes. Then a team of researchers did a summary of an evidence profile that is done following the GRADE recommendations. Just very basically, it helped us to see if we need to downgrade the evidence because the evidence might not be of the best quality, right? This could be because there are some risk of bias in the studies that we found. There are maybe in the network meta-analysis, everything is just on direct comparisons instead of direct comparisons. This always it entails a bit less quality than direct comparison, or there's publication bias, etc. The usual reasons for having a risk of some risk of bias in your research, right? Once this is done, we presented the panel with the evidence on effectiveness and also with contextual analysis and cost effectiveness studies of each of the interventions that some other partners developed. And the panel put everything together, okay, all the information of the different outcomes, the contextual analysis and the cost effectiveness information to build a recommendation. As I was saying, maybe we found something is slightly effective, but it's very expensive. This maybe then it's not very strong recommendation to implement. Or in the other, and in comparison, something is slightly less effective, but it's much more cost effective to implement. And so this has a stronger recommendation, for example. And this, we have also included it in our platform. And this is already something that might be more of interest to, let's say, for example, managers of health system, decision makers, and so on, because it already includes everything. It's integrated. It's more processed, let's say. It's not so raw data from effectiveness studies, but a bit more processed. So in this case, we also have it in our platform. I'm going to show you just slightly, for example, an example. If we go for recommendations of disease, we see all the interventions that had some backing by the panel, that the panel say, okay, this is good enough to be recommended. And then if you would go into one of those, you could see a lot of details. So for example, in implement, you not only have the raw data, but you have like some considerations on how to implement this intervention. Then, for example, you have all an evidence profile with much more detail, and say, for example, cost effectiveness. We have the summary. Okay, this intervention per patient is only €4. So then maybe this is something that you want to consider. And then you have a bit more detail of the analysis of cost effectiveness, and so on and so forth. And then you have this sort of summary of judgment. Okay, the problem that this is addressing is priority. The effects are moderate. There are no undesirable effects. The evidence is low, right? So you always you will need to consider. So this is like a way of making it much more synthesized for someone that is considering and implementing sort of self-management interventions. Now, if we speak a little bit more specifically about how we worked with our platform, or we are trying to work, we're still on it. For us, it was very essential to have the user perspective in mind, right? As I said, because we have this challenge of different stakeholders, we wanted to involve them, all the different types of stakeholders as much as possible throughout the process. As a central point, we had a platform task force where we had our researchers, but also external patients involved, because they were one of our main stakeholders, and they helped us to start designing the platform, and then step by step in a co-design process, reviewing. We then had an external patient panel, which periodically reviewed some of the products that we were putting on the platform, especially the ones that are more addressed to patients, and they would give us feedback about the navigation, about the language, about the usability of the platform in general. And then we had like a more formal exercise of user testing with some, in this case, patients, where they went through some of our products and they gave like a formal feedback. We also had workshop with the industry. As I said, some of our products we thought were more interested for the pharmaceutical industry or for in technology industry in the field of health. And we had a workshop with them to get their feedback. Then we had a usability assessment. We had a series of interviews with managers and policymakers for the products that are more addressed to them, reviewing them and seeing how we could present it a bit more friendly, etc. And then we had a piloting, just as like one of the last steps, to have the general feedback about all the sections in the platform. Now, what we have as a summary in the main resources in our platform, we have the repositories. This is what I showed you before, the repository of tools that, for example, use Adherence, the repository of RCTs that have analyzed a specific outcome or specific type of population, etc. Then we also have the net meta-analysis results. As I said, this is like more direct for researchers or someone that wants to keep doing research on self-management interventions. We don't expect patients or clinicians to go into this detail. Then we had this package of products that we think are more relevant now for clinicians and managers, decision makers, from the summary of findings that are very like detailed in terms of effectiveness to more process presentations like the recommendations that I just show you and the evidence to decision frameworks that are these sort of tables summarizing. All of this is complemented with contextual analysis and cost effectiveness analysis that are presented in our platform as well in more detail. And then we also have patient decision aids that is the main product that we have more addressed to patient and to the interaction of the patient with the clinician. So in this case, we all have also structured into 4 diseases, as you can see: type 2 diabetes, obesity, COPD, heart failure. Now I'm going to take you through one example of the decision aid, but if you want to do it while I speak, in your case, for other condition or other outcomes, you can do it here. You can see the address platform.selfmanagement.eu, and you can directly write decision aids, or you can navigate the platform and find them. And yeah, I would invite you to do it, because then maybe when we have the questions and the discussions, you have more feedback to give us. Now you will see, and now we will run through that our decision aids are structured in these 5 steps. So first we ask the patient what are the outcomes, the health effects that they would like to pursue. Then we present with the different options that we have found in the literature, the different types of self-management interventions that they might be interested in, that they might have a preference. And then we say, okay, first stop, does it work? Have we found something in the literature with your preferences that already we find evidence that they are effective? And if so, they would just finalize the process with some basic data about themselves, and then they can have their summary and they can print it. So if we are to do this together now, as I said, if you want to do 4 different, you can do it. In fact, yes, please go ahead. You will see that you will have at the beginning just an explanation of decision aids with like some text on why maybe you are interested in doing them. Now, let's say that I am a diabetic patient, and yeah, I want to start a decision aid. Now I can see here all the outcomes that we have found in the literature that we think are important for patients, and there's some evidence. And let's say, for example, oh, I forget to say before, as you saw, our results weren't super strong for adherence. And this, in our case, the panels didn't include adherence as one of the critical outcomes to make recommendations, just because of this, the evidence wasn't so much there. So it wasn't like the best criterion that we could use to recommend or not recommend an intervention. So yeah, it's tricky to work on adherence. It's so important for us as well, but I have to say that we have found limited evidence, unfortunately. But now let's say I'm a patient and maybe I want one of the typical outcomes, right, of glycosylated hemoglobin. This is like my main concern. And then I would come here and now I'm explained that I can choose now if I have a preference about what type of sort of intervention I might be interested in. So let's say that, okay, I'm interested in remote. I don't want to go to the clinical, the primary care center or whatever very often. And oh, maybe I have no preference. If it's individual or group, I might be open to both. And then let's say, okay, because I'm interested in glycosylated hemoglobin, I'm thinking that, yeah, I would like monitoring techniques because it will help me, right, to keep track. And I say, let's say, and also emotional techniques, right? I'm feeling a bit stressed about managing diabetes, and I want some support in that. You can see that always a patient can say, I have no preference because I don't know about it and I just don't have preference. But in this hypothetical case, we have, and here, okay, yes, we found some evidence for this combination. And here you could see, okay, you have all these options that can help you with glycosylated hemoglobin. So monitoring, action-based and emotional-based type of interventions with social support, even led by peers. This is ordered by the level of evidence, and then slightly different iterations you can see of monitoring with always action and emotional base and social support. So a list of interventions, but of course, probably, well, if you're doing this with a clinician, okay, you want to be focused on those that there's more effect. If I was following this, I could then go to the next stage and finalize the process. I would be asked a little bit about myself. This is not stored in our website, for example. I think this is very relevant, especially if you also do probations. It's not stored at all. It's only one-off. You get it and you decide if you want to print it or not. So let's imagine that I'm 60 years old and I was diagnosed 5 years ago, and I am doing insulin already. And imagine I'm not still doing lifestyle changes. Let's imagine I don't have any related health complications. I haven't undergone any surgical intervention. Let's say, yes, I have other health problems, because this is the reality of most patients. And I don't know, we could imagine that I have heart disease. And we ask about how confident you feel. Maybe I'm not feeling very confident because I'm a bit stressed about it. And I want to discuss maybe what should I do with my provider, right? And then this takes a little bit of while, but I would get my summary of what I have selected. And ideally, you could either do this with your clinician already at the moment of the consult, or maybe you could take it to your consultation with your clinician and discuss, okay, this is my preferences, and this can help you to have the conversation, right? So you can see here's like the summary. We try to make it a little bit visual, and there's always the option to print it and take it with you if you want. Okay, so this would be our last main product in our platform. Oops, excuse me. And then, of course, we are also concerned with the future of the platform. As Alex was already saying, we always have to keep thinking about the sustainability of what we do, right? After all the effort, how are we going to make sure that it outlasts the project itself? And for us, we foresee two main challenges. One of them is, of course, how we keep the information up to date, because always that you do literature review, it's so much effort, but then it's so quickly out of date because there are new studies coming in all the time. And then we also have another great challenge is like, okay, how even if we try to make our platform friendly, we cannot kid ourselves, like, or not all clinicians are going to come to our platform and check their possibilities constantly. Like, how could we make the information available for the clinician or the patient or a decision maker when they really need it, right? Not when they remember that maybe this is resource, but when they are working. And for this, we have taken like two actions. One of them that for us were really nice was that we had a hackathon event, and then we invited a lot of young IT people and teams across Europe for a couple of days, and we presented them with these challenges and all our data sets and all our structure of our platform, and they suggested us ideas to make them better, to make it to how to integrate maybe, for example, our information into already existing information system of some hospitals, so that when a clinician is starting, let's say, a diagnosis of diabetes, they have a pop-up, oh, maybe you want to check out this self-management options, and how to keep the information up to date. There were also amazing ideas on how to automatize the process of literature review, with artificial intelligence, with machine learning, and so on. So this, we cannot implement everything that was there, but this gives us a lot of ideas on what we could do in the future to make it more sustainable. And we are also developing a business plan. In our case, not a business plan to create directly revenue for us with our ideas, but just to make it sustainable. Like, could we find a way where we can have like someone that is keeping up to date the platform, that is having some dissemination and this sort of effort that allows us to make it to outlive the project and to actually be used by our intended stakeholders. And this would be everything from my side. I hope it was interesting for you, and I'm very open to the discussion now. Thank you.
Yep, thanks a lot, Marta. It's really impressive what you have managed to achieve. I think I have quite a lot of questions, I think, for also on how you developed it, and also on what would be your advice for users and so on. I would like first to give the floor to the other people present to ask their questions. Any questions? Anyone can raise a hand, open the microphone, and ask. Marcia?
Yes, thank you very much, Marta, for a very impressive presentation, for all the work that you've done. It's really amazing, and the website looks great, you know. And I was wondering, do you have any statistics already on how often it is used, or what kind of people are using the website?
The key question. We have just recently launched our platform. So yes, we are collecting statistics, but for now it's limited. The use, and we see that for now, it looks like, because we don't have all the information, but the people that want to give us information, it looks like mainly researchers. And then, because in our case, one of our partners is EPF, the European Patient Forum, maybe you know, and they are the umbrella organization from patient organizations. So from there, of course, they can disseminate, and internally we have some users from patient organizations that are looking into it. But yeah, this is still the very first stages from our exploiting the platform. So hopefully in the next months, we can report something a bit more detailed.
Any other questions? Any question also for discussion, maybe in relation to compare you and our aims? Bernard?
Yeah, I was impressed by the platform as well. Congratulations. Do you plan to do updates automatically, or does it need human being and human thought behind it? I assume you have to rank the quality of those papers and so on, which are hard to do by AI. I don't know. I just submitted a EU project and got a 4 ranking by AI immediately, you know.
Oh, wow.
So that's changing.
Oh, wow. From the best of our insight now is that for now, we will need some human supervision of artificial intelligence for sure.
Okay.
But we are, not us in our hackathon, but we have found there's some teams that have quite an advanced tool in identifying the risk of bias of the literature. They are called Robot Reviewer. I think they are based in the UK, I think in Cambridge, I wouldn't want to be mistaken, but in the UK. And they are pretty amazing in identifying the risk of bias, which I think is one of the more complex things to do with artificial intelligence, as you said. But they are pretty good. They have tested it against now thousands and thousands and thousands of papers and the assessment of a person. And they showed us some of the of a test, and it was actually, yeah, pretty good already there. So maybe we are not so far away. We in our hackathon, we asked the participants to look into other variables. So for example, characteristics of the patient or some of the effectiveness results. And it was impressive because there were some of the teams, like a young teams of 5 people, who in 2 days managed to actually do a test that worked pretty well with some of the characteristics that we were doing. Only like 2 days with a test. And we're like, wow.
Yeah, sure.
So this, for us, it would mean that maybe if you can invest in developing that and adjust it to your project, maybe you need to do a quality check. But now we do like an extraction and a quality check. If we don't do the extraction and we just focus on quality check with very expert people, this would reduce our workload in half, and we'd probably increase the quality, because we could have someone very specialized in the intervention, for example, analyzing that, instead of having like 30 people extracting the data and trying to train them all and so on, right?
Yeah.
So it's promising. It looks very promising, surprisingly promising.
It all goes in the direction of standardization. You know, at the end, there is little room for innovation.
At least for literature review.
Yeah, exactly. Yeah, but when you have to be well ranked in the literature review and it happens through AI, then it needs to be standardized, and that's a whole discussion we had also in the Emerge project. How much is it? How far should we go in the standardization, and how much do we leave for innovation and new ideas? You know, because the more you standardize, the less you leave room for new ideas.
Yeah, that is also true. There's always like the balance, right? Yeah, between be very sure that you standardize correctly, and then what do you lose in that process?
Yep.
Yeah, in relation to this, I was quite impressed by your comment regarding the lack of the gaps in the literature, and also the fact that the information is available in such a way that this synthesis is not possible. And I was wondering, is there a way from what you've learned in the process to feed back to the people that are generating research, so that they coordinate towards filling those gaps? Or because I think it's a two-way process in a way.
Yeah.
What your thoughts are?
Yeah, absolutely. So for us, we see different ways in which we can incentivize. I think one of the, let's say, flashiest ideas, and I think it's more ambitious idea, but we would really like, is that we in our platform we want to include like a step-to-step guide of designing your own RCT for self-management, where you could be suggested, okay, these are the outcomes that we already know that for self-management interventions are important for patients, so please at least include these top 6. And then we already, and also we could say these are what you should include, but also we see that's very little evidence on these outcomes. So if you can also measure these, it would be fantastic. And then, okay, the taxonomy of interventions, please consider these elements on your intervention when you're doing it, and also describe them when you publish the literature, because sometimes it's not that they haven't considered, it's just that they don't describe it in the literature, so you don't know, and you try to email them and you never hear back, right? So you're always left with the question.
Yeah.
This would be our flashiest idea, but also we have more let's say down-to-earth ideas. One of this is like with the taxonomy and publishing the taxonomy, we hope that other people, if they design an RCT, maybe they try and look into taxonomies, and many of us do, into okay, what's already there. And then with the cost, there's already some initiatives internationally or having core outcome sets where like they encourage researchers, not only for self-management, but for any type of intervention, to first look into if there's a core outcome set agreed by patients, researchers, and so on, and that they would include. And we want to include our core outcome set for self-management in that repository so that future researchers can have them. And yeah, we'll see, it's very difficult to influence, but we'll try.
Yeah, it almost feels like also every stakeholder can contribute with a little part of their activities, and probably just funded locally, so that in the end the information it's shared and it's merged together in this way to reach the other users, basically.
Yeah, take the most advantage of what we all of us do individually to reach. I think something that's interesting as well, that this is not us, but that is a development, is that maybe you have heard that now they are doing a live network meta-analysis where broad research networks just agree, okay, we are all going to be doing clinical trials, so let's agree that we all have in common this a couple of outcomes, and then also agree on like how we define interventions, and then we will be able to make sure that we are then able to compare our results. And I think this is also very interesting, that you not only register in the already existing websites, but that you coordinate with others, that so that you can take the most of our clinical trial, because if we are researchers, I think we all want to make the most. If you and other stakeholders will also be thankful that we do the best.
Yeah, and to decide what to share and what to keep also for yourself, particularly if your funding is more through the private and not public funding.
Yeah, for sure.
Are there any questions from the other people attending, participating? because I think I have a few ones that are quite sort of practical in a way. From your experience in developing the platform, what would you advise? I mean, we're kind of starting in a way that we have done, you know, the structure of the repository, the conceptual mapping, as you call it, and then the Delphi analysis. We have a form to fill in and so on. But now we feel like the maybe the hardest work starts, although the the previous one wasn't easy to to cope with either. What would be your advice in putting together all this information, and what were the main challenges you came across, and how you managed to the finish line?
Yeah, I mean, this is a very broad. I think for us, what it was useful is to speak with the stakeholders and see kind of what sort of questions they want answered. Because for us, it was useful to put it like in terms of questions, right? So for example, a manager would tell us, okay, I'm all for self-management, but which intervention is good for my context? And then a patient would be, yeah, okay, everything is fine, but like as I said, like I'm not interested in in glycosylated hemoglobin. I just want quality of life. And so for us, this was very interesting because once we had some ideas of this, we could like take the steps back. So, okay, how we managed to present
Answer
this
that question.
information to them, right? What I forgot to say is that one of the things that we want to add in the platform is that you have to do option when you come to the website, that you have to option to say if you are a patient or researcher, so on, if you want, and then you would see different options already presented to you, right? So if I say a patient already, we would like highlight the patient decision aids and some lay language materials that we have. If you are a researcher, we might guide you to some other resources, which for us, this was helpful because we wanted to have sort of everything together in a platform, but then to facilitate the navigation to different stakeholders. So I would say this is the most useful. And then our recommendation, and my recommendation from experience is, if as much time you have for like iteration, the better, right? So if you can have like a design, maybe a design just in a PowerPoint or whatever tool you want to use. Okay, so one more or less, you have a team that agrees, and then you present it to brother team, and then right, and then you put it in the platform, and then new ideas emerge and new problems as well. As much time as you have for that sort of iteration, the better, because once you're there and you start to think, you always have like new ideas. Oh, we could do this and that, and then you sort of run out of time. For us, at least now that we have a basic platform, we would like to have like one more year to work on it and to disseminate it and so on.
Yeah. At least I think for the amount of information that is there. Yeah, probably a plan for communicating to many people, and also I think probably across disciplines, because I mean, as a health psychologist, I'm interested in self-management from one angle, but I guess, you know, as a clinician working in diabetes or heart failure, that you're interested in other things and want to know some other sections of the website. And the way you've described it today, it's full of messages for each of these people. What would be your advice for Enable members, knowing the platform? How could they use it, and what would it be for them, a way to engage with the platform, or maybe to collaborate, or maybe start a new project?
Yeah, I mean, first of all, because we are in the beta version, if you guys like go into the platform and just navigate freely, if you have any feedback, you will see that we have like an open box. We would really appreciate if you have any recommendations for us as well, because we are trying to gather inputs for people external to our project. So this would be super helpful for us. I think for you, I think if you are focusing within your project, if you are focusing on adherence, probably the most interesting is this sort of repositories. Because as I said, we didn't find like super strong evidence for adherence from self-management perspective. But if you go to the repositories and you see the RCTs, you will find like some interesting initiatives and even if the paper didn't have the most strong evidence, maybe they have evolved because they published 3 years ago and now they are doing something new that they haven't published yet and so on. So I think this is like a very basic way of taking advantage of our information.
And just to clarify, this is basically results from a systematic review that you have done on all the topics and including adherence to medication and to treatment in general, no?
Yeah.
Up to until 3 years ago. That's
yeah,
this is what
exactly.
they will find there.
So that's what we have there. I think that would be useful. And then I think what might, if you are interested a bit more broadly, if you go to the part of the recommendations, I think in your case is probably the evidence to decision frameworks or the recommendations themselves can be useful because you can see different interventions compared and like the pros and cons of each of them. And a lot of them do include technologies. And you saw that even if we haven't found like a very robust conclusion on adherence, still there are quite a significant amount of studies that include adherence there. And there you can see already some reflections on some of the barriers to get that intervention that includes adherence. So some of them you will see, for example, for technologies, one of the barriers that we have is that still there are some interventions that are very expensive. That's they are monitoring us on, you need like a specific hardware and so on. And then of course this is an important cost for a health system or insurer to take on for an intervention. So this, I think this can be relevant for your reflections on health technology. And then you can also see some reflections that we collected in the contextual factors for technologies. And here it's not only us, we had like also like a Delphi process and experts involved and all that we could extract from the literature on the contextual factors that were relevant. And for example, some of them, if you involve new technology, well, then you need like a big important training program for the professionals themselves, also for the patient. But maybe you need to train all your professionals into using that technology and integrating it into their daily life, right? And this might be more complicated than having a more traditional intervention where I just have a group of patients with social support. So hopefully.
Talking about training, how about is there any training for users to not only to use the platform but also to think around the concepts that you're presenting there? I think one of the things that we've discovered through the Enable work so far is that people are talking different languages and they are coming from very different angles. So something that might be obvious to a researcher is not obvious to a clinician and or to a patient or to a technology developer and so on. And we're trying to do some things together and we need that common base. How was your experience? And
yeah, I think we also find it because you have come from different disciplines and also sometimes language. Like sometimes we were like, we as more experienced self-management interventions, we were trying to speak with our statistical colleagues that are Greek and they are super experts in network meta-analysis. We weren't, and then it was like 4 languages there, right? Spanish, Greek, and then self-management and network meta-analysis. And even within us, trying to understand each other was a challenge. I think as a very basic for us, what's very useful to do this like taxonomy and this like core concepts because it gives us like a basic levels of like the components of what we were going to analyze as the first stage. But then for the external users of the platform, I think we are facing the same challenge. We don't have a magic solution, but we are trying to do the same where we are developing like lay language explanations before each of the tools, explaining why they're used. And we are now developing like short videos explaining like the platform, the project, then the self-management interventions, and then the platform itself and how to navigate it so that if someone is motivated to use them, but maybe they are not very confident, they can have some guidance on that.
So for the users of the platform, including the Enable members who want to experiment more with explore more the platform, that could be also a starting point to look at the videos when they will be ready.
They are not available, but
yeah, when
they
ready.
should be available.
Yeah.
This is our our objective. And as I said, if we manage to do this like guided navigation, then we think this also allows us to introduce much more, like if you're a patient, we can introduce much more explanation if you want it for some of the tools, whereas if you are a researcher and you are already an expert in network meta-analysis, we don't need to guide you through everything. We can just present you the option to download our data and use it. Right.
So more of it like the decision aid that you've showed for the patient. That could be something similar to decide
exactly.
what they want, what they know already, and what they want to explore more.
Exactly.
Okay. Any other questions while we are discussing?
One question: how many literature review did you do in total for this
Massive
project?
work.
Yes, we did like 4 separate literature reviews, one per disease for the interventions, and let me check because I have it somewhere here, the actual number. Yeah, in the end, we included 1,600 randomized clinical trials in our evidence for the 4 diseases.
For the 4 diseases, okay.
Yeah, we found many more, but when we applied our inclusion criteria for the type of intervention, a minimum quality, and like they are actually randomized control and so on, this is in the end. And one other criteria that they measured some of our outcomes of interest, because there are some studies out there that are good quality, but they maybe were measuring a very specific outcome that wasn't prioritized for us.
And this data could be available for further analysis or for collaborations with other research teams that want to look into more depth on some outcomes or in some conditions as well.
We have everything like in the background, it's uploaded to the platform, and we want to make it as open as possible. So right now it's not, because as you can imagine, we are in the process of publishing some papers with the results, and we need to limit some of the evidence. All the evidence is visible now in the platform, but our idea is that once we have the major papers published, that the evidence is just downloadable from the platform, and you can just get the data set and work on it or do a more specific analysis, because you can imagine also there are so many possibilities of exploiting some specific. For example, if you are interested in adherence, okay, maybe you want to look not for all the interventions that we did, but for a specific group, or you want to do a subgroup of patients by sex, by gender, by age, by if they have comorbidities or not. We have a lot of information there to have more specific analysis, and ideally others will use it as well. I think something that we also did that it might be useful for you to think is like we have developed our platform in a way that's compatible with APIs that you probably know better than I, but I'm told that they are tools that are allowed to make it better integrated with other websites, other information systems, so that they can use maybe part of they don't need to come to our platform. Maybe they take the information from our platform part that is relevant to them, and then they can integrate, because most of people won't need all the information that we have. And as I said, if ideally, like if maybe, let's say, a patient organization wants to promote self-management and they are a COPD organization, they could potentially exploit like information for only COPD or only the patient decision aids or something like that.
Any other questions?
Can I ask you then maybe a question like, do you have any like sort of preliminary results or insights about what technology is being used for adherence overall in your studies? Like, and is it working or not? Maybe more general terms.
I think for the moment we are just starting the search for technologies in a more also systematic way. I think we have some examples, and I think many of the Enable members are also have developed or are working with technologies like from devices to measure adherence, to medications in different administration modes, to apps for medication support. Yeah, so it can be a wide range of technologies, but I think now we're trying to more systematically search in each country, to ask members to make a search locally. And also bring this information so that we can corroborate it in the platform. I think our approach also from the beginning is also aiming to organize the development of country some national centers for medication adherence, given that the health systems are so different across Europe, and also sometimes also within countries. In different regions, it can be a different organization. So we're trying to encourage this. I think since the start of the action, several countries have made steps more or less at advanced stages at the moment, but I think each of the countries participating has done some national activities as well for raising awareness, involving stakeholders. And I think for the next 2 years, the plan is to be able to support this development, and in the same time provide a sort of common structure so that people can organize around the 3 objectives of the action, which is identify best practices, identify also technologies that are available, and also importantly, the third aspect is how can we make technologies and best practices more implementable, which is I think that the challenge that we have also focused on quite a lot, because interventions might be there, or at least for some areas, and the evidence might support some points, but when it comes to actually seeing it happen like in routine practice, that's the third complexity that we need to tackle. So that's kind of the plan we're trying to apply for the next 2 years. Yeah, mainly encourage more events, training schools, and also think of a sustainability plan for this as well.
Yeah, we'll follow closely your results, and because I said we are also very interested, and because for us, when we do our reflection, we will kind of do it like a mapping of, and for us, of course, adherence is like one of the first crucial steps that we need for everything else to occur. And it was a bit disappointing that we didn't find more evidence or more evidence on effectiveness of interventions that had found a way to make it a bit, to increase adherence, to keep adherence a bit more higher.
But if I can, I think the problem with adherence is the definition of adherence. There is nothing such adherence. And just, I would like to ask you one question about, I see you have blood pressure as an outcome. Did you have office blood pressure? Did you have ABPM? Did you have self-monitored blood pressure? Did you mix everything? Because that's also when you have HbA1c, it's pretty clear. When you have weight, it's pretty clear. Adherence, it's daily, it changes daily. And I could see a parallel with blood pressure, but most of the time, most of the study on blood pressure will be office blood pressure, I guess.
Yeah, exactly. For the great majority, it was taken by the clinician. Yeah.
Has its value and limitations, but it's a single number. It's easy.
Yes.
And adherence research, and we have discussed that extensively with Alex in different projects, from ABC to Enable and more. No, not Enable, Emerge. And so the problem is really the definition of it. And okay, there is a taxonomy today, but still people mix it around.
Absolutely. Yeah, for us, it was one of the challenges as well. I think I highlighted at the beginning also this repository of tools, because when I was preparing the presentation, I thought that you might be interested for a specific tool or more specific definition of adherence, because for us, because we weren't focused so much in adherence, we were trying to have like a more general conclusion. But I can imagine that you might be more interested in adherence as measured by this tool or these couple of tools that are relatively similar among them, and that's why in our platform you could find like the RCTs that specifically measure with that tool, because yeah, it was super complex. And in our case, that as I said, because it was prioritized also for broader terms in diabetes especially, everyone agreed, okay, lifestyle behaviors is very important. So also we are interested in adherence to lifestyle behaviors, but then of course you are combining like, okay, to physical activity recommendations, to healthy eating. To healthy eating, maybe it's just to overall diet, Mediterranean diet, or it is like to salt consumption and so on. So of course you are mixing completely different things, and this has many limitations, but that's why I think if you're interested in a specific definition, you could find it through there.
Okay.
And also in the data set, I understand, select the ones that are particularly focused on adherence to medication and to a particular type of measure.
Of tool. And then you could also, I think also one of the challenges that you have in adherence is like a lot of times it's self-reported, or almost always self-reported. So that has its own biases. And even sometimes you have a lot of dropouts into the adherence to the adherence measure, right? Like people are just not reporting if they adhere to the behavior or the medication taken. So
30% will not fill a self-report.
So yeah, there you go. You have a big challenge.
Yeah. So if I understood correctly, I will just try to also to summarize a bit of discussion and perhaps also the next step. So you are the project ends at the end of this month, no? So there's going to
the
be
year.
at the end of the year.
Months,
okay,
yes.
okay. And then so there is a final symposium organized this month, and then it's going to be also soon a symposium or an event where also people can participate online.
Yeah, I will send you, Alex, the information. So if you want to circulate it in the consortium and people are interested to join, we would be very happy to welcome you.
Yeah. Okay, so this is one event to look forward in your inbox, and also I understand that people can just access the platform now, search for information, and give feedback about what they found, ask questions eventually if they're interested to collaborate on some aspects, have ideas about how they can continue to work with the Compare EU consortium in the long run. And also maybe set up research for the gaps in the evidence that are seen there, in particular for adherence to medication. I understand that we have quite a lot of work to do, right? So we need to start working on those gaps. And
yeah, and if I can say, Alex, just please don't be shy to contact us, because already from our project, for example, we have established a stable collaboration among some of the partners on self-management in Europe, with this precisely the idea to make the platform and then also the study of self-management more sustainable. And we are thinking about, we are already identifying some funding opportunities for related projects with our current project. So yeah, if anyone like has an idea or wants to collaborate, we are also looking into this, like actively looking into this. So please do contact us. And
in relation to, in particular, to adherence to medication, if there are tools that we identify to measure adherence, or if there are tools to or interventions published that are more recent, and maybe we want to collaborate on updating the part of the review that is in relation to adherence to medication, we just contact you, look on the website, and there we find the contact details so that we can continue collaborating.
Yes, please.
Thank you very much. Thank you for the time today, and good luck with wrapping up this part of the project and continuing it in the next years. And if there are no other questions, I just want to thank everyone for joining today, and thank you, Marta, for taking the time to explain to us. We keep in touch for sure by email.
Yeah, no, thank you for having me, and all the best for your project. We will follow it as well closely.